You
But
met someone else.
I could not start it without, telling everyone may the fourth be with you. I'm a huge Star Wars geek, so I had to do it. But this week we have Julie presenting. I'm always excited to hear what you have to say, Julie.
Yeah.
And
Thank you.
can
May the
go ahead.
fourth be with you too. And thank you, the Northwell crew, for the salad. It's delicious. It gave me an option to turn on closed captioning, so I hope that this is okay and not distracting, but I just said it would make it more inclusive. But I'm just going to talk about some cool cases. So feel free to speak up, ask questions and share stories as we go along, because I really would love to make this a discussion. So our first case, and I talked to some of you about this already, but this is a 17-year-old girl who is presenting with right shoulder pain 5 weeks after a surgery for a torn labrum. And she's just in excruciating pain. So I got her assigned out at 7 a.m. She's been in the ED for 10 hours awaiting a read from her overnight MRI of her shoulder. Her pain's 10 out of 10, despite Tylenol, Toradol, morphine. And the team signing her out said, even if she doesn't get admitted to ortho, she may need to be admitted for pain control because it's just completely uncontrollable. So the MRI ultimately showed a bursitis that surgery was just planning on following as an outpatient. So there was literally nothing that could be done for her shoulder. So just curious, what are some people's thoughts on the next steps? And I'll have the chat open. So, because I would love to monitor that if you feel more comfortable. Any thoughts about what you could do for pain control for her?
I think because the forum we are probably like regional anesthesia by ultrasound.
Wow. I love that idea. So I thought to myself, so I did a point of care ultrasound fellowship, which was basically split between the pediatric side and the adult side. And the adults use regional nerve blocks all the time. So I knew that there were these blocks that you could use, and this had come up in something that we talked about. But we decided to do an interscalene nerve block. So just a thumbs up or show of hands or write in the chat. Has anyone done this before? Or anyone thought to do it? So this basically is going to target the nerve roots sort of right up here. So C5 to C7. Henry says, I am not brave enough. So you are not alone. I was hoping someone would say that, because now I'm going to embarrass Antonio. So this was the text conversation within our PEMPROCUS group. We're using Antonio's last nerve block kit for an interscalene nerve block. Antonio is so passionate about nerve blocks that he takes his own time to make nerve block kits so that we could just grab and go. And he really encourages us to use them. And then he sends us this emoji or this GIF. So I think I gave Antonio a couple of gray hairs, but yeah, so standing a needle in the neck, you're not alone. That definitely makes people nervous. So just to go through with it. So targeting nerve roots C5, C6, C7, you can't really count on covering C8 or T1. And you'll also notice the phrenic nerve is labeled right up there on the top of the screen. So we'll come back to this later, but that's one of the biggest pearls or pitfalls about this block, that you basically assume that you're going to knock out the phrenic nerve temporarily. So don't do it in someone with respiratory distress or pulmonary pathology, but in a young, healthy kid, you're clear to proceed. So just to let you know, full disclaimer, the images that I'm about to show you are taken from highlandultrasound.com. It's my primary resource for nerve blocks. I highly recommend you check it out. You can also look at the POCUS Atlas. They have a lot of great tutorials on nerve blocks. So this block is going to cover the axillary nerve and some of the lateral aspect of the arm. It's perfect for shoulder pain from surgery, shoulder dislocation, proximal humerus fracture, or deltoid abscess. So here are the landmarks that you're looking for. You're going to be looking for this traffic light pattern, they call it. So right over here. this is like, they call it the traffic light. So that's going to appear between the anterior scalene and the middle scalene muscles at the level of the cricoid cartilage. So you have your linear probe and transverse orientation at the level of the cricoid cartilage, like mid-clavicular. It's like 2 to 3 centimeters superior to the midpoint of the clavicle. And so the patient's supine, head rotated 30 degrees to the opposite side, you put the probe in the interscalene groove, and then you're going to find the brachial plexus. And yes, we are very close to the carotid and the IJ, but we're on the opposite side of the anterior scalene, and we're watching with the ultrasound probe the whole time. So here's how it looks on ultrasound with our traffic light pattern, C5, C6, C7, C8. So that's what you're looking for. So you want to clean thoroughly with chlorhexidine. We used a 22 gauge 3 centimeter spinal needle. You want to try for a blunt tip needle when you do these nerve blocks. And then, so here's just a dynamic clip of the structures, just to give you a sense of the anatomy there. And you're going to want to keep the needle away from the nerve roots to avoid nerve injury, but you're just going to want to infiltrate right around the nerve. I don't actually have a picture of infiltrating around the nerve. This is not from my patient. This is from Dr. Rainier von Tonder and the Yale adult EM side. And this was our view. So you have here I like to look for the it's called I'm blanking. So here's the anterior scalene and the middle scalene muscles. I'm like blanking right now. Okay, and then the SCM in the front there, anterior scalene, middle scalene, and then the SCM on top, right? And where the SCM is tapering, that's where you're gonna, it's like the opposite side that you're gonna be entering the needle. So here's your SCM on top, and then the anterior scalene and the middle scalene muscles. So we injected 6 cc's of bupivacaine. The pre-procedure pain was 9 out of 10. The post-procedure pain was 0 out of 10 at the 5 to 10 minute mark. And it lasted for 12 hours. The patient was thrilled. So I would call it a success. I was very happy with it. Erica asked, can you comment on regional block versus intra-articular block choices? Why one versus the other? It's a great question. Yeah, because definitely another option would be an intra-articular block of the shoulder joint. And that's something that is really easy to do for shoulder dislocation, especially you have a nice big hematoma there that you can aspirate some blood and then inject the lidocaine in there before your reduction, which I know Antonio has done as well. So why one versus the other? I don't have a good reason. I think in this particular case, I think I was probably nervous to go into the joint because of the bursitis and the prior surgery, but I don't know if that's a legitimate concern. I think certainly the interscalene block or regional nerve block, that'll cover more ground. So certainly that'll be a powerful tool for the for a humerus fracture or or some kind of skin abscess that needs to be drained. But you do bring up a good point. For a shoulder specific thing, you could certainly do an intra-articular block. Any other comments or questions about that?
And Julie, this block can be used also for shoulder dislocation as well, right?
Yeah, you could use it for shoulder dislocation. Absolutely.
Any, I don't know if anyone else has done that, or, because in theory and the way you're showing it, I feel like this one's could be a little easier to do than actually the intra-articular, because sometimes, finding this longer needle, you're going into actual capsule. So I don't know if people routinely have used this block instead for shoulder dislocation. So I feel like, I've seen this in a couple of times, the way you describe it, it seems so superficial, so easy to, so it seems like this would be an easier one to do rather than the intra-articular if I were to compare both of them in terms of the technique.
Julie, I was going to say the the landmarks, if you can go back to like that first image you showed, are super close to the superficial cervical plexus. I think it was back a couple. Yeah, maybe even one. Like they're literally adjacent. So
You want to annotate here? Wait, I'm gonna have you annotate here.
yeah, so I don't know.
Annotate on the screen
Right.
to just illustrate what you're talking about.
Show me how. Sorry, I'm getting help.
Oh, I love that you're here. You're the nerf block expert du jour.
And then you just pick like a.
Give me like, let me draw. Yeah. So this, I don't know if you're able, are you able to see the cursor? Oh, sorry, give me a sec.
And pick what you want.
It's Matt's fault.
My fault, sorry.
Just start.
Yep.
Can you see this, Julie?
Now.
How about now?
Oh, yeah, there you go.
All right, so that's the superficial cervical plexus. So in terms of people like learning to be comfortable putting needles into the neck, I like this block a lot because you literally enter like half a centimeter into the person's body, right? So I'm almost thinking like, and then the corollary is if you're going to do this block, look for these landmarks, kind of learn them, right? And then you've done, I don't know, 3 superficial cervical plexus blocks, and then maybe, you know, you've built up the confidence and comfort level to try the next level, you know?
And I'm actually not as familiar with the cervical plexus block, but what is that going to cover?
It's beautiful. So when I come to Yale in 2 weeks, I'll be reviewing this one. But so the main things it covers are the skin of the majority of the neck, the earlobe, and the clavicle. So it's kind of a multifaceted block. The time I'm most using it is for like embedded earrings. But like, I like talking about it because everyone's instinct is like, oh, I'm going to put a needle in someone's neck, right? But you're literally like, look at the distance we're talking about here. It's like almost nothing, right? And then you kind of build in your comfort, and then you go, you know, into the brachial plexus theoretically.
Quick question: do you guys put topical anesthetic when you do this, or you just like, you know?
So the first thing I do when I'm thinking about a block is putting LMX over like the area in question.
Oh, I like that idea. Yeah, I've been doing a wheel of Lido. My
Yeah,
leg is prepping with the LMX, just like you would do with any other time you're piercing the skin.
So no, not to bogart the conversation, Julie, but
No, this is the whole reason I love this.
so the wheel, right? So if you're gonna put in a central, like a central line in the neck, right? So you do the wheel, and then the other thing is at the way end, you know how you have to like suture the line to the person's like chest, basically. So kind of the algorithm that someone suggested to me, which makes a lot of sense. You're looking for the landmarks anyways. So the first thing you do is you drop some lidocaine here over the superficial cervical plexus. That resolves the need to do a wheel, which, you know, saves you that step. And then also at the end has anesthetized the skin, whereby you'd be, you know, suturing something into someone's like chest soft tissue. So that's just another thought, but
Yeah, I like that idea. Thanks, Binder.
Julie, it's Matt. Can you hear me?
Yeah.
I'm in my car.
Yeah.
The couple things I was going to add to that is like so I have not had the occasion to do the brachial plexus in peds. I've offered it several times, and each time had teenagers decline or ortho decline 1 point for concern for their exam, which was a little bit preposterous. We've done on the adult side, and I've actually had our fellows do it on me, which was fun. I typically just do a little wheel for those as well. The one thing I would say with those is our group and our anesthesia group are both pretty hesitant to do a long acting agent because of the phrenic drop. And so, like, you know, you assume it's going to happen. So not having something that's going to be long lasting in case, oopsie, you're breathing with one diaphragm. Young, healthy kid, it's probably going to be fine, but it's certainly something to keep in mind. So we would typically do, you know, Lido for a shorter, you know, for procedural side, but not something that's going to be like longer acting pain relief. The cervical plexus one, our guys do pretty much for all their IJs for the reasons that Zach was mentioning. Those I would typically probably just do a straight, like, because it's so shallow, go like straight to just a 27, like a simple 27 hypodermic, in which case the skin wheel is probably a moot point because it's so small anyway. It's kind of like doing a forearm block. That was it.
Right. It's like doing a wheel for placing a PIV, you're placing the needle anyway, so you might as well just do the block.
I find Freezy spray actually is fairly helpful with those, though. Just a quick
I
little.
like that. Or the LMX makes sense. Just
Yeah,
to create-
I'm
just to
totally,
start with LMX.
no, I was just gonna say, I'm totally over the wheel. It's either LMX or nothing at this point for me, but
This is a great conversation. Thank you. I actually do, I did a little bit of lit review about that phrenic nerve block and about the potential complications, just because I think this is something we talked about a lot. But there's not a lot of literature that I found that quantified the complication rate. I know people talk about it a lot, the potential complications, but in terms of strong literature to support it. I thought this article was interesting because these were not being performed by the POCUS expert or anesthesia. This was ortho performing them. So this was actually a single orthopod that was performing these. So he had success on first attempt, 99.9%, and a total complication incidence of 2.3%, no recorded life-threatening complications. Again, single, very seasoned orthopod in 1,322 cases of shoulder surgery. So the breakdown of the 2.3% of complications, so they did have hoarseness and Horner syndrome in some folks that they stated improved with conservative treatment. And it seems that the concern for phrenic nerve palsy is more associated with high doses of anesthetic, so like 20 cc's. But for our purposes, it's recommended to only do 5 cc's. So this was shoulder surgery. We're only using, we did 6 cc's. And it was actually, so I was actually finding a lot of case reports of phrenic nerve palsy when the interscalene block was used for shoulder surgery. So here's another, this is 100% incidence of hemidiaphragmatic paresis associated with interscalene brachial plexus anesthesia as diagnosed by ultrasonography. So this isn't like necessarily even clinically relevant. They're actually using ultrasound to detect phrenic nerve palsy and record, even if it's subclinical. So here they used 34 to 52 cc's, which I don't even know how you inject that much into. And then they used 1.5% mepivacaine. So all experienced paradoxical motion is measured by ultrasound at the 5-minute mark, and all could overcome the paradoxical heavy diaphragmatic motion through intentional deep breathing. So they all had it. 11 of them were followed postoperatively. 10 out of 11 resolved to normal between 3 to 4 hours. 1 out of 11 resolved by 5 hours. And only 5 of the patients had any symptoms, and that was mild dyspnea. So it's real, but is it clinically relevant? Maybe not. So that's sort of what I have for the interscalene nerve block. And I again invite any other discussion. But here are my pearls and pitfalls. Keep away from the carotid and internal jugular, and you're entering the needle on the opposite side of the anterior scalene. Keep away from the nerve roots and assume that you may cause some amount of phrenic paralysis. So just avoid in patients with a tenuous respiratory status. But that being said, if they're young and healthy and have no pulmonary issues, then you should be okay. Anything else that anyone wants to add? Because I really like this conversation. Then I have just other cool cases. All right, we'll go on. And if you think of anything, we can always come back to it. The next case is a 19-year-old woman presenting with dysuria, hematuria, and right flank pain. She had initially been prescribed macrobid by the PCP for UTI, and then today she presented with fever, sent to the ED for possible infected stone or pyelo. So she was febrile, she had rigors, she really did not look good. And she had right CVA, right flank, and suprapubic tenderness to palpation. So here's her urine, positive Lukes, 20 white blood cells, 14 RBCs. And she eventually grew out E. coli There's no bacteria on the UA, but also remember that this was after 24 hours of macrobid, so maybe that made a difference in that. And then, so here's my ultrasound of the right kidney. So I'm seeing, I don't know if the gain might be a little bit of an issue, and but there's some trace free fluid superior at the superior pole of the right kidney, and does anyone see these sort of anechoic areas? So I was wondering if that was represented maybe a renal abscess. Does anyone else have any other thoughts about those? And I put some color on it, so this is just what it looks like with color Doppler. Again, I don't know if you're able to see it that well on the screen.
Yeah, Julie. I think the kidney just looks like more heterogeneous than I sort of would expect, and I agree that looks very prominent at the anechoic areas. So
Yeah,
I'd be suspecting the same thing.
yeah. Thanks. And then here's the bladder. So to me, it looked like there's some thickened bladder walls. And then here's the CAT scan. So the right kidney shows a focal rounded perfusion deficit in its superior pole, concerning for focal pyelonephritis. No drainable or rim enhancing fluid collection, periureteral straining around the proximal aspect of the right ureter, no urinary calculus, no hydronephrosis. So I was actually, I just brought this up because I was surprised to see that there was no abscess or fluid collection. We were just seeing focal pyelonephritis, and that's just what it looks like. So I thought that was just an interesting, ultrasound finding. This kid was admitted for IV ceftriaxone and discharged on ceftonir. All right. So our next case, I think this is a indication that I've heard a bunch of the people in the audience here use it for, but this is a 5-year-old who's coming in from ortho urgent care billed as nursemaid's elbow and sent for quote unquote reduction under sedation. And the mechanism was that he was hit in his arm by a swing. So the x-ray was read as negative at the urgent care, and mom was instructed to take a photo of the x-ray to prove that it was negative to us, to show us what was found. And they did multiple nurse rate reduction attempts at the urgent care, and they were unsuccessful. So he was sent in a splint, and he had obvious swelling and bruising of his right proximal forearm. So not to, badmouth the ortho urgent care, they're doing a good job. They do, they're trying their best, but, just to sort of, just like a reminder to maintain a level of, our own level of suspicion, and don't trust anyone, and do your, to not have premature closure. But I think many of you would agree that the story and what I'm describing on exam sounds like not usually consistent with a nursemaid's elbow. So I went ahead and did an ultrasound, and does anyone have any thoughts about that? And this is while, mom's showing me the photo of the negative x-ray. But so what we're seeing here, so here we're on the posterior elbow, here we're in longitudinal plane, and then here we're in transverse plane. And we're looking at the olecranon fossa in longitudinal and transverse plane, and we're seeing that nice hematoma that tells us that there's some kind of intra-articular fracture. So here's the x-ray, and there was a minimally displaced condylar fracture. Oh, any thoughts? I just thought it was nice, like ultrasound was a really nice, powerful tool that I could show them at the bedside, that, despite that negative x-ray that they must have showed the family over and over, told them to take a picture, here's another picture that they could see visually, that there was in fact blood and a fracture that was missed. All right, our next one is a 3-year-old boy presenting with cough and shortness of breath. He's waiting for admission to the PICU on 14 liters of high flow nasal cannula. So he was initially, he initially had a respiratory rate of 50 in the 50s, stats in the 80s. He was unable to speak in complete sentences. And he responded to dual nebs and continuous albuterol, but was continuing to require high flow nasal cannula for increased rate of breathing. So these were all focal areas in the right upper lung field. And the remaining right lung field was normal, and all of the left lung field was normal. So does anyone want to share their interpretation of this, or just take a look and think to yourself, or write in the comments?
Are you going to play the videos, Julie, or just the stills?
Oh, thanks for the reminder. Guess I didn't make that on automatic loop.
I mean, I think I see bronchograms and the focal B lines there, and with that story, I would treat.
Yeah, so I'm curious who would treat. That's the whole reason as soon as I had this case and saw the follow, I was really curious to bring it to you. Because I agree with you. I'm seeing some confluent B lines, that subpleural lesion over here that looks like it's at least 1 centimeter. And over here, there's this lesion, maybe just under 1 centimeter. Here it's probably about 1 centimeter. We usually use centimeter as the cutoff. And Rahul says you would treat too. Because I felt like I would treat too. So I showed this to the chest x-ray showed a possible right lower lobe pneumonia versus that electasis, which is always kind of interesting because this was right upper lobe. And I showed these POCUS images to the team and gave my interpretation and said, I think you should treat. I mean, given the clinical picture and these ultrasound images. And they said that they weren't inclined to treat. And I left my interpretation pretty objective in the chart. I didn't give a recommendation. I just described the confluent B lines and, the 1 centimeter subpleural lesion. And I didn't, give any kind of conclusion beyond that. I left it objective. And the patient was never started on antibiotics and was weaned easily and discharged 2 days later. So I think that Rahul previously had done a series on these lung ultrasounds that were sort of, had very clearly positive features, but maybe were borderline, or maybe were treated when you wouldn't necessarily treat, or weren't treated when you would treat in the follow-up. So does anyone else have any other thoughts about that? Anyone who would see this and would not treat?
Julie, one of the discussions I had with one of the hospitalists was when I had some similar situations. It was they asked me to get labs, and then we'll look at the procal, and then their justification is the procal is high, it's likely bacterial, and then they treat it. What I've done with these in these cases, sometimes I just tell them I just started on POCUS and I started AMP, and then I haven't been good about following up and whether they continue in my AMP. But I just feel better that if I'm pretty confident it is. I just start on my AMP and I put in my note POCUS showed findings consistent with pneumonia, and then admitted. And then I haven't been really good about in terms of how many of those patients that we admitted have continued on on antibiotics, or if they stop them.
Yeah.
Hey, Julie, it's Erica.
Hey, Erica.
So, I'm really interested in this topic, and I have been scanning a lot of viral children on purpose just to see what their lungs look like if clinically they don't look like they're pneumonia. So they have some bronchiolitis, they are afebrile, and there's a lot of viral kids that look like this, with this confluent B lines and maybe a subpleural lesion. And so I feel like this picture to me, unless they have obvious air bronchograms that is a good size, I actually tend not to treat, and I use a lot of my clinical picture to kind of see whether I should treat or not. So if they have prolonged fever, they are tachypnic, and and they have ultrasound findings, I'm more likely to treat those. If I only see confluent B lines and maybe a subpleural consolidation here and there, I don't treat those, because I'm seeing a lot of viral kids that, you know, the X-ray read is like, you know, atelectasis versus pneumonia versus inflammatory something. Like, we've got a lot of hedgy X-ray reads this year, I feel like. So I've been scanning all of those hedgy reads to see what the POCUS looks like, and many of them look like this.
That's so interesting. Yeah, I'm glad you brought that up. So the question is, I feel like we've traditionally used 1 centimeter as the cutoff, but maybe that's not an appropriate tool based on what you're saying. Like, maybe, because I do see sometimes like 1 to 2 centimeters that I still feel like look like bronchiolitis. So maybe the size is not as important as like the air bronchograms like you're describing, or I don't know. Maybe there's other ways that we should be describing this cutoff between viral and bacterial.
Yeah, I have something to comment on that. The paper that came out a while ago, where they randomized kids to X-ray versus POCUS first, like routine care versus POCUS first, they found that they did a lot better in terms of radiological stewardship when they randomized them to get a lung POCUS first, but the POCUS arm actually got more antibiotics. So it ended up being kind of a trade-off between antibiotic stewardship and radiological stewardship. Because, you know, if you start looking, you will find things. And I think it's a good reminder that when we look at chest X-rays, there's a lot of pneumonias on chest X-rays that are somewhere on the spectrum of looking virally versus looking bacterially. And I think in ultrasound, we're starting to encounter that as well. And so where I trained, we did actually use procalcitonin as kind of a tiebreaker for an ambiguous chest X-ray that could be either viral or bacterial. And I think that with ultrasound, as we gain more experience with the spectrum of viral versus bacterial findings, that we can use procalcitonin probably in the same way.
That's really helpful. Yeah. I like Stephanie Cohen's chat, what she wrote in the chat box, size matters not. May the 4th be with you. Any other thoughts about that?
Does anyone know, like, I don't know if Miss seen you know, the study regarding like POCUS findings and like along with procal or any other inflammatory marker, like sort of like as a tiebreaker, because you know that's also something that's sometimes been done here depending on the attending. So I don't know if someone's run into that, because I don't remember off the top of my head if there's been a study like that.
Yeah, my institution where I did residency used 0.5 as the cutoff. For neonatal sepsis, procal has more evidence in the 2nd month of life. So, you know, it just depends, like that's a PCARN level. My institution used this paper that I think that came from a Spanish group primarily, as a lot of the support for their study. And the Spanish group has done a lot of work with procalcitonin. I'll try and dig up the paper I mentioned before and the procalcitonin one that I'm also referring to and put them in the chat. Give me a moment. I'll plug it in as we go along.
So I'm still not convinced that a lesion such as this by ultrasound is pneumonia as opposed to atelectasis. And so I struggle, and this I think was reinforced during a WinFocus presentation that I viewed this past year, where an intensivist essentially showed us a series of patients with atelectasis and showed the which looks in some cases even worse than the images that Julie's putting up. And then with increased positive pressure, increase of PEEP, you could see that dynamic improvement in the appearance by lung POCUS. So that's number one, because it's on the smaller side, although there's B lines, you know, confluent all around it. And number two, if it's pneumonia, you know, in a 14-month-old, our hospitalists and our pediatricians and ID will say, well, it's going to be, you know, given the prevalence of viral pneumonia in this age group under 2 years is higher than community-acquired pneumonia by strep pneumonia or some other bacterial pathogen. But of course, you know, I don't think we're going to be able to differentiate viral versus bacterial pneumonia on imaging findings alone, which are earlier on in the process. So perhaps just like ear infections, there is a future where we do wait and see high dose amoxicillin for something that looks like this on patients that we can discharge. But anyways, I think it's this conversation along with what Rahul sort of presented not too long ago is ripe for, let's just put our heads together and figure this out and what to do best. Because I also don't think I want to practice medicine by getting a procalcitonin to sort of decide if I'm going to do antibiotics or not in a kid that I think is not sick enough to come into the hospital. You know, I don't know if I want to put a child through a venopuncture procedure if I otherwise didn't think that they would need it for some other reason. So anyway, I just think there's so much here from a pediatric patient-centered care standpoint that we need to figure out.
Yeah, I agree. I think we collectively, and I think that like our team and like P2, I think we're like the people who are going to do it. So I thought there was a pneumonia study that they spoke about at P2 like in 2019. But I haven't really heard anything more about it. But maybe we should restart that. All right.
I think that one is Sam Lamb's baby, and he hasn't found anybody to take it.
Okay. All right. Well, maybe we can take something like that on. All right, next patient, 11-year-old male with vomiting, diarrhea, abdominal pain for 10 days. So he actually he had been to the PCP. He had been to the PCP multiple times over the past 10 days, sent blood, stool, urine studies by verbal report. The CRP was 133, ESR was 33, EBV, monospot, Lyme were negative, stool studies and urinalysis were negative. And he was sent in for workup of continued fever and elevated inflammatory markers. And they were specifically concerned about MIS-C because of the abdominal pain and vomiting. And this was like at the height of MIS-C. So on exam, he was tired of hearing, uncomfortable, but non-toxic. He was focally tender in the right lower quadrant. Any comments on what you're seeing here?
Double shotgun sign. I love that sign.
Double shotguns. Although I've never heard it referred to a finding in the pelvis, but we can call it that.
I thought that's for dilated CBD.
Yeah,
That's
CBD.
what I call the double barrel shotgun sign is for the widened or the enlarged CBD. Is there another one that I don't know
I think
about?
Henry wants to say double bladder, but he said double
bladder sign.
I consider them the same, you know, he's still the same thing. So it's not supposed to be there.
Something that's there that's not supposed to be there. I agree with that. So we have an abscess in our bladder. So just to orient everyone, sagittal orientation, and then this hypoechoic heterogeneous structure just superior to the bladder, which given the clinical history and exam, I felt like this was probably a perforated appendicitis. So I started antibiotics and consulted pediatric surgery, and that was before the kid even went over to the radiology performed ultrasound. So that I felt like was a cool use of focus that expedited management. And then this kid was admitted for IR drainage. What's the TIE fighter sign? Oh, wait, that's Antonio taught me about the TIE fighter sign. That's the
that's where you have massive free fluid in the pelvis in a female. And so the fluid causes pressure on the uterus. Let me see if I can find a picture, but and And so it looks like the TIE fighter from Star Wars, going with the Star Wars motif.
Yeah, total Star Wars theme today.
Stephanie, I had my first like a week or two ago, so we talked about it a little bit.
Oh,
It's like it's that common.
Yeah, if you're able to post a link in the chat, that would be great. All right. I think this is my last one. But I have a 16-year-old boy with I spelled lupus wrong, but lupus, I recognize that there's a U. Lupus nephritis, prior pleural effusions and recurrent fevers and URI symptoms here for cough and increased work of breathing. So he had some mild tachycardia, and he was significantly diminished on the right side and had an agophony in the right lung field. So I feel like anytime you see these sort of like lung lobes floating in a pleural effusion, you have to name it. So there we go. We got the jellyfish sign. Squidward. It's a pretty good one, right? So, and then here's our cardiac views, and then Josh says the claw. Oh, I'm sorry. Did I just attach? Okay. Sorry, I just entered our next case, which I did not have a transition slide for. But yes, Cohen's was on fire. Thank you for those excellent suggestions as to this, as to the name for this ultrasonographic sign. We have time for one more. So, I do have a last case that I realized that I just put the clips in at the end of, I call the bow tie sign. I'm looking at what Stephanie Cohen put into the chat. So she has a really nice example there. I'm going to put it up on the screen. Can you see it? So there's the TIE fighter sign. So the bladder in the transverse plane, and you have ascites below, and then the uterus in the middle, and that makes a really nice TIE fighter sign. All right. I'm going to save this last case for next time. Are there any other thoughts or comments?
No, those were really nice cases, and actually, you know, like as you said, I really appreciate the discussion. So I think that's what makes this great. So I appreciate all the input from everyone. So that's, you know, that's why I like doing this, because I learn something every time. So
yeah, I really appreciate the discussion as well, and I appreciate everyone sharing their experiences. And oh, I see that there's the procalcitonin measurements for guiding antibiotic treatment in pediatric pneumonia. So that was in 2011. So they use a cutoff of 0.5 for procalcitonin. So that's interesting. So something we can share more in the future and talk about. Maybe we could put together a case series and publish, or make a algorithm or something. I think that would be useful.
yeah, I think that would be great, especially with you know, Erica, you know, she's saying she's scanning a lot of them. So I think you know, if a bunch of us start doing that, then maybe we can find some type of specific finding that we can do, and then do a case series. I think that would be great.
Yeah. Oh.
We just have to find an eager fellow to start it off. So, but yeah, but thank you, Julie, for presenting. And I forgot to mention, it was nice seeing a lot of you at P2 Network, which I thought was a success. So, but yeah, thank you again, Julie, and thanks everyone.
Thank you. Thanks for having me.